the next speaker, Dr. Jayesh Rahalkar, who is a very eminent clinician, known academician, and the chairman of the DIBO also, to take over. And he's also a professor at the D.Y. Patil Dental College in Pune. He's a consultant at the Dinanath Mangeshkar Hospital. And a very important contribution that he has done during these troubled times is to go on COVID duty himself. And that's something that we really appreciate. And a big salute to you, Jayesh, and welcome, as well as I would urge you to take it forward with your presentation, which is on simplifying or reducing the uncertainty in treatment planning. Thank you very much.
Thank you very much, Dr. Chetan, for the wonderful presentation. I always get envied of the PG students for getting such a fantastic opportunity to learn during their undergraduation. I just would like to go back in time machine and relearn all those things. I would have been a different person today. So first of all, thank you to you for giving an opportunity to these PG students to have such type of learning initiative. And thank you very much, Agesha and Reena madam, for all the support. I'm just sharing my screen. Is my screen visible?
Yes.
Okay. So as the ball was set rolling by Dr. Chetan in this morning, uh, first of all, I welcome you all, the students, delegates, the speakers, my eminent friends, Dr. Chetan, Dr. Vinod, Dr. Vignesh, Dr. Suryakanta, Dr. Umal. Uh, we all know that the MDS final exam is a very important part in every student's life. And after the theory examination is over, the practical examination where the student is going to face the examiner is a very important matter. And as orthodontics is a clinical branch, many times majority part of our interaction with the examiner, which we can call it as a grand viva, long case viva, for that matter even pedagogy, for that matter even the functional appliance part, the part of your own cases presentation. Orthodontics being a clinical branch, majority of the questions pertain to the treatment planning and how the treatment has happened or how you are going to do the treatment. And we all know that orthodontics, for that matter any biological science, is not an exact science, so variability is there, and this particular variability leads to some uncertainties in the treatment planning. Now, these uncertainties are because of many reasons. It could be because of understanding of the disease process, that is the etiology of the malocclusion, what was in the yesteryears and what is in current years with the evidence on the you know the treatment modalities which are done for a particular type of malocclusion a few decades back, which could have been initially empirical, and then later on when evidence started gathering about it, some things were shade down, some new things were added. And that's the reason what happens is that every person undergoes unlearning part of the previous thing, learning part of the new thing, and relearning of the evidence based or evidence supported modalities. So because of this particular flux of change in every person, there are a lot of uncertainties which happen during these treatment planning parts. So I'm going to talk about the various uncertainties which are there in the treatment planning. Some I'm going to touch upon some controversies and my input to the students from the exam point of view, as well as from the practice point of view. Because see, you have to remember that MDS examination is beginning of your own individual learning process, because when in 3 years you are under the learning process which is governed by your seniors, staff members from the department, senior staff members. But after you complete your MDS, it is your own learning process which has to be governed by you. So I'm going to talk from both point of view. So I'll start with very favorite saying of mine, quoted by Swami Vivekananda. He says, education is knowing something of everything and everything of something. And how I put it to orthodontics is, post graduation is knowing something of every dental specialty and everything of one dental specialty, that is our orthodontics. And it is coined by some postgraduate guides. So as Dr. Chetan mentioned, in the viva or in any interaction, when you are answering to the examiners, you should be knowing lot of stuff about orthodontics, but at the same time don't forget that you basically are also a dentist, and there are many times from the orthodontic questions some dental questions are also asked about materials, about when you're talking about an interdisciplinary thing, some disease processes from other specialty will be asked, modalities of treatment from other specialties will be asked. So it is necessary for every orthodontist that they should be well aware about the most important and basic parts of all the dental specialties. Now, where are the times of uncertainties you are going to face during your postgraduate examination on those 2 days is mainly about the treatment planning. So we will be talking about the uncertainties in the treatment planning. And as Dr. Chetan rightly mentioned, that majority of the controversies and the uncertainties are going to happen in the first day, first show of your examinations. You remember, usually functional appliance exercise is the first exercise the student does, and that is where the interaction of the student with the examiner is going to happen. And that is where how confident you are, how well read you are, how composed you are in putting up your understanding of orthodontics matters. And that is where and we know that functional appliance has a lot of controversies associated with it, so which we are going to discuss. So the first time where the discussion about uncertainty of the treatment plan is going to happen is when you're talking about your diagnosis and the treatment plan of the functional appliance case on the first part of your practical examination. Then the second thing which is going to happen, the uncertainty where there are variable treatment plans. And as it was mentioned in the previous lecture, you have to have one ideal treatment plan, and if it is not accepted because of many reasons, an alternate treatment plan should be ready. So next thing is going to come is in your long case. The long case is where you're going to discuss this particular treatment plan and diagnosis of the case in your viva, the grand viva, on the probably on the second day. Then after the functional appliance exercise is over, you'll be showing the treated cases which are treated by you during the time of your postgraduate training. Now, when you are displaying these particular cases, what happens is that this is again where the treatment plan is going to be discussed. One benefit of the treatment planning defense in treated cases is that usually these cases are discussed in the department during your case presentations, and majority of the staff members will be putting their collective wisdom, and the final treatment plan is going to be ready of those treated cases. But sometime, even after doing so much of discussion and all the team of staff members and the PG students deciding a particular way of treatment, there could be some non-acceptance or variability of the treatment modality by the examiner. So even if the decision of treatment plan may not be required to be done on that particular day, whatever treatment planning is done, you have to defend that particular treatment plan when you are presenting the case. So again, that is where discussion is going to happen. And as I said, I'm going to talk about a little bit. 5% of my talk will be for the future of what you're going to do after MDS. You all are going to be, practicing clinicians. All are going to be definitely practicing clinicians. So take my word. After 25 years of clinical practice, which is actually exclusive orthodontic practice, this uncertainty and dilemmas are there in clinical practice many times, which we face. So this uncertainty doesn't end, we try to just reduce it. When I was a postgraduate student, the confusion and the uncertainty, suppose it was 30%, today it has gone down to 5%, but it is still there. And as a clinician, my success is when I keep on this uncertainty, keep on reducing it to 1 or 2%, it will never be 0%. If it becomes 0%, then I have stopped learning. I'm not accepting any new thing. So these are the areas where uncertainty will come when you're doing a treatment planning in your orthodontic clinician's career. So what is best, they say that what is the simile between the parachutes and the mind? You know, parachutes and the mind of a clinician works best when both are open. Parachute in a bag will not work. It will work only when it is open. Same thing applies to the mind of a clinician. The clinician's mind should open, then only it will give the best result. And remember the management lesson: never start a project unless all resources are available. How it applies to orthodontics is that whenever you are given a case, say let's say a functional case or a long case, see to it that whatever diagnostic records or analysis or images are being given to you, you have to, these are all resources, you have to properly analyze them and then only come to your final treatment planning. You have to be, don't jump to conclusions just by looking at the patient clinically, or looking at the patient of the cephalogram of the patient, or looking at the cast of the patient, or looking at the photograph of the patient. Don't do that. Use all the resources together, and never ever forget this diagnostic and treatment planning flow chart. Probably you may not be having an interview of the patient when a long case is given, but you can talk to the patient of the functional appliance case after collecting all the diagnostic records, whatever database you have got. Prepare a proper problem list along with a proper diagnosis. The diagnosis has to be proper with the skeletal diagnosis in all three planes of the space, the dental diagnosis, the soft tissue diagnosis, and when you have the functional appliance case, the functional diagnosis is very, very important. So after you prepare that, then sort out the problems, the orthodontic problems and the other dental problems. The reason is that there are some dental problems may have some interaction on orthodontic problems, like for example a non-restorable tooth, or where the prognosis, endodontic prognosis or the prosthetic prognosis of a particular tooth is bad. It is going to affect the orthodontic treatment. So it is always better to make the list of orthodontic problems in the priority order, okay, where consideration to the chief complaint of the patient, along with from the clinical point of view, what the clinician finds it very important. So the priority listing can be two ways again: the priority listing as per the patient's requirement, and the priority listing as per the scientific analysis of the case by the clinician. Then make the other dental problems, and then considering the interaction of various orthodontic solution to these problems and the dental problems, optimize the complete treatment plan. And after you optimize the treatment plan, what is most important is that you need sequencing properly. Which particular treatment will be done first? What are going to be my steps? So this particular diagnostic and treatment planning chart is very important for the student to come to a proper diagnosis and treatment planning for the functional appliance case, for the long case which is given to you. And the most common mistake what we have seen students do is that these long cases are usually the department cases. So what they do is that they just ask the person who is doing the treatment, and then they don't use their own logic. Sometimes the treatment plan which has been done or which has been told to you by that particular student might be a single-sided treatment plan. The case might not have been discussed in the department. So use your own logic, your own knowledge to come to the exact treatment plan of that particular case, which may not match with what is the treatment plan the person has told you. But this particular treatment plan, what you have decided, will have a proper analysis. If it is done, then defending that particular treatment plan is always better. Like in many exams after MDS, let's say the MRth examination or even the IBO examination, the examiners do accept that one case may have more than one treatment plan which can be acceptable. Okay, so if the clinician can give a proper justification why he has chosen this particular treatment plan and not the second one, it will be very well accepted by all the examiners. So remember to follow these steps in your functional appliance cases on day one, and if you properly do that, it will convey a message to the examiner that this particular student is very methodical in coming to the conclusion. Okay, so even if in the remaining 2 days you falter somewhere, this particular first impression, because what as an orthodontic examiner the examiner wants to know is whether this particular student is safe enough to be scot-free as an orthodontist in the society. That is the simple way. So if the examiner comes to know that he analyzes all records properly, he has a method of doing it, then it conveys them that yes, the protocol he is following is fine, but what he probably just lacks is the experience. And as the method, the scientific knowledge and experience starts coming in, then only the clinician becomes a wise clinician. So remember to follow these diagnostic jargons. And I know this is what your reaction is going to be. This is the most common reaction of our postgraduate students as well. Okay, now coming to the uncertainties, I have renamed them as the uncertainties, controversies, and the dilemmas in the field of orthodontics. And let's list what are the various dilemmas in the orthodontic, because the uncertainty or the controversy of any treatment plan comes because of these dilemmas. The first is one phase versus two phase treatment. Majority of the examiners in your first day functional appliance examination section are going to talk about what is your take or what you know about one phase versus two phase treatment. So reading the controversies and all the articles about supporting one phase treatment or early treatment, so the late treatment and the two phase treatment, where early treatment is done and followed by a second phase of treatment, you have to read them all. They are mandatory. I call some reading as vital in MDS examination, and if you have not read that, your situation will be non-vital. Then extraction versus non-extraction. I'm going to take each controversy and show in two different cases and then discuss about some references. Then the next controversy is extraction versus non-extraction, which we know that in the department itself, one teacher says, okay, go ahead for this particular case with extraction. The other says, don't go ahead with extraction, do non-extraction. And the same dilemma persists even in treatment planning during the clinical practice as well. Then with suppose any case requires a expansion of the maxillary arches, then whether to go in for the rapid palatal expansion or micro implanted assisted rapid palatal expansion, that I'm going to talk about. Then whether to use MARPE, that is a monocortical implants for expansion, or the maxillary skeletal expander which uses bicortical engagement. Then very important is to treat a skeletal dysplasia case with either a surgical correction or a non-surgical correction, that is camouflage. And surgery first versus conventional orthognathic surgery approach. The skeletal malocclusion treatment planning and the controversies and other details will be taken by my dear friend Dr. Umal in the lecture series during the summit time. I'm just going to just touch upon everything will be taken in detail when he'll talk about the management of skeletal malocclusion. So let's come to the first controversy, that is one phase versus two phase treatment. So initially the concept of two phase treatment was in vogue, where the first phase of the treatment was usually a growth modulation, and the second phase of treatment will be a fixed mechanotherapy for tooth size arch length discrepancy, and then getting the finish of the occlusion more better. And it was necessary that the phase 1 and the phase 2 treatment must have some gap in between. Okay, so usually the phase 1 treatment was done in the early mixed dentition, and the phase 2 treatment was done when in the early permanent or mid permanent dentition. And there has to be phase 1 treatment will have a duration which will be followed by a period of no treatment or observation, and then the second phase of treatment will start with fixed mechanotherapy. And one phase treatment where you either directly start with mechanotherapy, where you manage the tooth size arch length discrepancy, or use some functional appliances which could be fixed functional or in combination with fixed appliances for the correction of skeletal malocclusion. Even class 2 elastics are used in some centers as correction of mandibular retrognathism. But one phase treatment sometimes, there is a controversy which some proponents say that one phase treatment can also have an initial step of growth modulation, which could be by a removable appliance and immediately followed by fixed mechanotherapy. Okay, so this particular two phase treatment, where there is a some time where the treatment is not done and the patient is kept under observation is not there, and the one phase treatment initially the growth modulation is carried out basically because the growth status of the patient is such where correcting the growth or the skeletal malocclusion is necessary first. So let's take an example. This particular patient reported to us, and the patient's chief complaint, or a mother's patient's mother's chief complaint, was that she has the teeth which are procline, and this particular patient was a player who used to play for skating, and she used to be on that rollerball tournaments. So she said that her teeth are jutting out, and I'm scared that if she falls while doing the skating, there might be damage to the dentition. So when we analyzed the case, we found that there was a class 2 with increased overjet, mandibular retrognathism, high frenal attachment, and this is how the patient was in the mixed dentition stage. And taking the history of the menses and other growth evaluation, it was known that this particular patient had a menses started, and height increase was there, but unfortunately the dentition was such that where we cannot think of this particular patient for one phase treatment. Plus the patient's mother also gave concerns about probable trauma to the incisors during the skating tournaments. So we decided to look at this. This is how the patient was, with a lot of eruptions still pending. So it was a classical mixed dentition stage. So we went ahead and gave a growth modulation appliance. The patient also had a tongue thrusting, so we modified the twin block appliance into along with the habit breaking appliance. A little bit of expansion screw was also built into it, and then the patient completed the first phase of treatment. Then the patient was kept under observation, and because of this correction, the patient's mother also felt that now the proclination of the incisors was there, which was there. The lip trap, because of the mandibular retrognathism, the patient had a mild lip trap, and because of which the incisors were very prone for trauma. So that was corrected, and then after the patient this is the classical tripoding which we say has happened, and the vertical also got corrected, and this is at the end of the first phase. Then we waited for a few days, and then we started with the fixed appliances. That is the second phase of treatment. And then when we completed, the reason, if you see, there is notching of the cervical vertebrae has started happening. So she was peaking up. Menses had started just 3-4 months before that. And then we went ahead and completed this particular case with a proper fixed mechanotherapy as the second phase of the treatment. So this particular patient was treated classically with a two-phase treatment, where the first phase was with growth modulation, and there was a waiting period in between, which was followed by the fixed appliances. And this is how the final finish of the case was. So now you can make out the patient is grown up, and this is how the patient before the phase 1 treatment, and this is at the end of the second phase of the treatment. Now here I want you to go through these articles, and these are very, very important articles. You must note down these articles. This is an article by the North Carolina team. This is the randomized control trial, Camilla Tulloch being the first author. This was published in American Journal of Orthodontics and Dentofacial Orthopedics in 1997. This particular study was done as a prospective study, because they said that all the studies which have been reported up till now were all retrospective study. And in this particular control clinical trials, what they did, there were patients in mixed dentition with increased overjet. This study has its own limitation, but this was one of the few studies which was a prospective study. This is the first part of the study where they have shown that when phase 1 treatment was done, the patients who received the treatment, they had a proper correction of the skeletal dysplasia. Okay. It concludes that the headgear group showed restricted forward movement of the maxilla, and the functional appliance group showed a greater increase in the mandibular ring. Okay. There was considerable variation in the pattern of change within all three groups. with about 80% of the treated children responding favorably. So the control group didn't show a lot of correction of skeletal dysplasia, but they have added one very important line in the abstract itself, and you read the article: the permanence of these skeletal changes and their impact on the subsequent treatment remains to be evaluated. So this was the first part of their prospective study, the control clinical trial. And in 2004 they came out with the second phase of the this particular same study. So they reported this as the outcomes in the two-phase randomized clinical trial of early class 2 treatment. This is published in AJODO 2004. So what they did is that, you all have, and those who are appearing for part 3, they should be knowing these 4-5 articles by heart now. So the conclusion of this particular second phase of treatment suggests that two-phase treatment started before adolescence in the mixed dentition might be no more clinically effective than one-phase treatment started during the adolescence in early to permanent dentition. Early treatment also appears to be less efficient in that it produced no reduction in the average time a child is in fixed appliance during the second stage of the treatment. So the first phase showed good correction of the cases which were under treatment, but when control group were also treated with fixed appliances, they also showed the same result. So the control group which didn't receive treatment in the first phase came to the same result at the end of second phase, even though in the first phase there was no treatment rendered to them. There are a lot of controversies about this particular study, about the selection criteria, about allocation criteria. There are a lot of issues, but this was one of the study which started slowly making the concept, because otherwise before these studies it was all cases which were treated with two-phase treatment. So slowly after this, majority of the cases are now slowly being shifted to one-phase treatment. So these are also some important articles which you must read. This is by Julia Bremen in AJODO 2002, efficiency of early and late class 2 division 2 treatment. Based on the result in this investigation, it was concluded that the treatment of class 2 division 1 malocclusion is more efficient in permanent dentition, that is late treatment, than it is in the mixed dentition, that is in early treatment. Okay, so and another study, this particular study, yeah, this is an important study. This is by the University of Florida. Timing of class 2 treatment skeletal changes comparing one phase and two phase treatment. This is in AJODO 2007. The conclusion says there is a temporary skeletal change as a result of phase 1 treatment with both appliances, but no detectable skeletal differences between one phase and two phase treatment of class 2 malocclusion by the end of full orthodontic treatment. This particular study is also having a similar pattern of the study which was done in North Carolina. Okay, and this is the study, the famous study by Kevin O'Brien, multi-center trial, which was done in United Kingdom. Early treatment for class 2 division 1 malocclusion with twin block appliance, a multi-center randomized control trial. The conclusion is twin block treatment when the child is 8 to 9 years old has no advantage over treatment started at an average age of 12.4 years. However, the cost of early treatment to the patient in terms of attendance and length of the appliance wear is increased. Here they have mentioned that if the only benefit is the psychological benefit and preventing the trauma to the incisors. So if you see, remember the first case which I showed, the patient's mother gave a specific history that this particular patient takes parts in skating tournaments. So that is where trauma to the incisors has maximum chance. That is the reason we decided to treat that particular patient in a two-phase manner. Now, going through this, you all must be slowly getting convinced that what is most important is majority of the cases will be now being treated in one-phase treatment. So this is again an early permanent symposium write-up by Wheeler, and this is also very important. This is published in AJODO in 2006, April 2006, the early treatment compendium. Please read that. Again, the similar type of conclusion. So what are the advantages of one phase treatment? There is reduction in actual treatment time, reduction in the retention after growth modulation, less taxation on patients' compliance, and more cost effective. So in the exam, when the examiner asks you about what is your opinion about, or what you know about one phase versus two phase treatment, quoting these articles is very, very important. Okay, so if you don't know these about these particular studies, it is the time to go back and read all these studies. So then the examiner will ask you, yes, now you have given me that, okay, one phase treatment has to be done, and these are the evidences. So do you have any protocol? So you can say that a well-defined protocol for each case is necessary, and the choice of the treatment, whether to go in for one phase treatment or a two phase treatment, should be based on growth status of the patient. Like in the first case, you saw that the patient was speaking up in the uh, mandibular growth. It was the patient's mother was giving history of menarche. The CVMI status was showing that within next 1 year the mandible is going to get peaked, but there were insufficient dental units to go in for fixed appliances. So one phase treatment was not possible in that particular patient. That is the reason we decided to treat that case with two phase scenario. So what is most important to be checked is growth status of the patient. We have to see to it that our growth modulation appliance has to be in the patient's mouth when the peak of mandibular growth is there. Okay, then growth direction. The choice of the appliance will depend on growth direction. That is whether the patient is showing a vertical pattern of growth, or whether the patient is showing horizontal pattern, or the normodivergent. So divergency of the growth, it will help us see the first thing, that is growth status of the patient, will help us in choosing the timing. The growth direction will help us in choosing what appliance to be used. Then state of dentition. The state of dentition also will help us to choose what appliance, because we have to see whether how the patient is having um, whether the patient is in the mixed dentition or early permanent dentition. In early permanent dentition, we can directly take this patient on one phase treatment. If the patient is showing mixed dentition, then we may have to take the patient on two phase treatment. Even about the choice of appliance, whether there is a crowding or there is some correction which is required, that also is very important to be evaluated. Nature of the dental malocclusion, that is the irregularities, deciding the duration of the pre-functional correction if required. If the patient's peak of puberty or peak of growth is not yet achieved, and it is going to be in the next 1 to 1.5 year, you have to think whether that particular first part can be utilized for correcting the minor dental irregularities which are there. And amount of incisor exposure, and I will add one more point, is the compliance of the patient, because the compliance of the patient is also very important when we are deciding. So after going through that, you have to tell the examiner that the decision of the functional appliance will be based, I will you know give the decision whether what is the growth status of the patient, growth direction, state of dentition, whether I require any pre-functional correction, what is the amount of incisal exposure, and what is the cooperation of the patient. Okay, because if the cooperation of the patient is not good, then thinking of removable appliance may not work. You may have to think about some fixed functional appliance. So this particular protocol will help you in coming to in answering the question, in coming to a choice about functional appliance, and also in your private practice. Then growth status of the patient. Remember, I'll just quote one because it's not within the purview. There are many people, Sassoon in 72, Pearson, Panches, Malmgren, Bassetti. The optimum timing for growth modulation of a class 2 is the active growth period, which should coincide with the pubertal growth spurt, irrespective of the treatment modality. But remember, this doesn't apply to class 3s, and it doesn't apply to management of class 2 where mandible is normal and maxilla is prognathic. Okay, because the cephalocaudal gradient will be different. In a class 2 where mandible is normal and maxilla is prognathic, mandibular growth stimulation is not the choice of treatment. Controlling the growth of maxilla is the choice of treatment. So don't if you have a hammer, you feel that each problem is like a nail. Remember, there are some screws also for which you need a screwdriver. Okay, so hammer is not the only equipment in your hand. Okay, now I'll show you another case. This particular patient. Now also remember that the previous case which I showed was a female. So this is a boy. This is a male. This is how he was. you can see his dentition is such that were only two deciduous teeth are there. His peaking of puberty is still late. His CVMI condition was such that we could have some time in we could extract these deciduous teeth which are about to exfoliate, align all these teeth, and then prepare this particular dentition to receive a fixed functional appliance. So because number one, he was on he in the earlier part of maturation, he was in CVMI 2. So we went ahead, put the patient on fixed appliances, and we gave functional appliances, we gave forces. Now this is what actually happened because of the lockdown. The patient couldn't come for checkup for around 4 to 6 months, and when the patient reported, there was a complete overcorrection which had done. He didn't, the time of removal of forces is also mandatory, but I went through some literature and we found that a little bit of overcorrection helps in improved settling after the functional appliance is removed. Because if you come edge to edge then and you finish in a little bit of class 3 mechanics, it helps in controlling the IMPA, the flaring of lower incisors. So we removed the functional appliance and started with finishing and detailing, and this is how the patient was in the finishing and detailing, and this is how the patient was at the end of the treatment. You can see here the patient's second molar couldn't have been banded, because that is very important when you're giving fixed functional appliance. Even the lower second molars were not erupted. So we went ahead and waited for them, and this is how the patient at the end of the treatment. So this is how you can make out the patient is at the end of the treatment. See here, look at the change. This is before and after cephalogram, before and after. This is before and after, and this is comparison before and after. And this is the OPG. So what is our take home message? That in the exam, there are going to be a lot of discussion about fixed functional appliance, timing, uh, type of appliance, bite, all those things you have to consider. About the bite, Dr. Chetan has already mentioned. So the protocol which I just now showed you, follow that particular protocol and have answer for each, so that the examiner will understand that you have thought about this particular case in a proper methodical sequence. Okay. Now extraction versus non-extraction. So this particular case came with a proclination. There was proclination. There the nose was little prominent. Nasolabial angle was on a higher side. So we went ahead and treated this particular patient non-extraction. Patient was still saying that, doctor, my teeth still look a little prominent, but we convinced that you have a dorsum hump here, and that is the reason it is better that we do not retract them more. Okay, the airway is also good, so let's not disturb it. And this is how the patient is at the end of the treatment. This is before and this is after. So some very important articles for extraction non-extraction comparison. This is an article which is by Packett, especially Dr. Lyle Johnson was the HOD that time. Long-term comparison of non-extraction and premolar extraction age-wise therapy in borderline class 2 patient. This was published in July 1992. So what they say here, our data provide little support to the popular concept of a single stable incisor angulation, and for the troublesome claims that premolar extraction, as opposed to expansion and bite jumping, must of necessity produce distal mandibular displacement and in the process flatten the profile enough to ruin the face. So they have proved that it is not that because of the extraction the flattening of the face happens. The result of their study showed for the borderline patient, non-extraction treatment produces significant more protrusive denture, about 2 millimeter, both at the end of the treatment and at recall over a decade later, because the recall was almost after 14 years. In general, the pattern of relapse was unrelated to the type of treatment or to the post-treatment position and orientation of the denture. Instead, it appears to constitute a dento-alveolar compensation produced by differential of the jaw growth of the patient. And there was no evidence that either treatment tend to produce distal displacement of the basal bone of the mandible or its condyle. Despite a significantly flatter profile, quote unquote, the extraction patients proved as likely to view their outcome as improvement as did their non-extraction cohorts. Okay, so this particular study again in AJODO 1995, where smile aesthetics after orthodontic treatment with and without extraction of 4 first premolars was evaluated. Here, what was important, there was a there were frontal photographs which were taken for a smiling patient for 60 retention patient, 20 from 3 different private practices, 30 with full edgewise appliance but no extraction, and 30 with extraction of first premolars, and they were evaluated by a panel of 10 lay people. And variables related to the buccal corridor or other measures to the relationship between the width of the dentition and the width of the mouth during the smile showed no relationship to extraction aesthetics. The results indicate that there is no predictable relationship between the extraction of premolars and the aesthetics of the smile. uh, this is a this is not exactly an extraction non-extraction debate, but this is extra basically how to use 3D effect on the face of extraction and non-extraction treatment, where skeletal class 1 pattern was there, and how they superimpose the 3D optical surface scans. And also, just for the sake of interest, you can go through that. And this is an article which is an Indian article which is published in Jan 2008, Journal of Dental and Orofacial Research, extraction versus non-extraction controversy or review. So this particular article has done a good review. I really liked it. What they mentioned, that the last 2 decades has seen noticeable decline of extraction in orthodontic treatment. This is augmented with increased pressure from referring dentists to treat the patient without extraction treatment modality, being unaware of the literature supportive of extraction in specific cases. Okay, that means they mean to say that the concept what people are saying, that treat each and every case without extraction, is not valid. There has to be a rationale for choosing between extraction and non-extraction. So this review provides a summary of historical background of the controversy, the perspectives of various authors, and the reasons for decline in extraction, and what is the present understanding of the debate. So this particular article will help you in 2 ways. They have summarized it nicely, and also the list of references include all important articles which are necessary to be read by a orthodontic postgraduate student who has to understand what is the how the debate between or the controversy between extraction non-extraction is there. So in the conclusion, what they say is very important. Identifying guidelines for the extraction versus non-extraction decision in orthodontic treatment is a complex task. Presently, the controversy is not afflicted by as much belief as it was almost 100 years ago, because it was mainly by belief. There was no evidence, and both treatment options are still open. The option to treat with extraction or non-extraction should be made objectively for each case based on strong evidence with equal attention on the soft tissue paradigm. So soft tissue evaluation as well as a proper evaluation of the crowding on the model analysis, cephalometric proclination. In the soft tissue paradigm, what is most important we must see is the lip strain. In our department, we have a study which was which got grant from ICMR, was on strain in the lip, and actually when the fallback of the lip starts after the strain is released. Okay, this is under publication, so once it is published I will quote that, but in the meantime I will tell you that unless and until the lip strain goes completely, the fallback of the lip doesn't start. So I have seen many times highly proclined cases are treated non-extraction because the nasolabial angle is higher. The nasolabial angle could be higher basically because of an upturned nose also. So what you need to understand, the nasolabial angle should have 2 components, the upper component and the lower component. So the nasolabial angle should be divided at subnasale by Frankfurt's horizontal line, and you should check what is the upper component, because if the nasolabial angle is high and the upper component is high, that indicates that the tip of the nose is upturned. What we need to know is what is the cant of the upper lip. If the cant of the upper lip is proclined, even if the nasolabial angle is higher and you retract, still the patient's aesthetic is going to look very nice from the frontal view. The patients are going to see them from the frontal view, and the aesthetics in the frontal view carries maximum importance. So in this article, what they have given is the hard tissue, the model analysis guidelines they have given, contemporary extraction guidelines. If the arch length discrepancy is less than 4 millimeter, extractions rarely indicated. If it is 5 to 9 millimeter arch length discrepancy, you can try between non-extraction, posterior expansion, and extraction. And this is where majority of the uncertainty of the treatment plan happens. So if the patient is having more than 9 millimeter, it's a frank extraction case. If it is less than 5 millimeters, it's a frank non-extraction case. Now between 5 to 9 millimeter, you have to weigh your decision on expansion. You have to weigh your decision about new modalities of treatment of using IZC, infrazygomatic implants, buccal shelf implants, extraction of third molars rather than premolars, and distalizing the dentition. So remember this particular chart. So 5 to 9 is borderline, below 5 non-extraction, above 9 is extraction. And the extraction in contemporary orthodontics, is now supported with the distalization of the arch with the help of infrazygomatic crest implants and the buccal shelf implants. And also we have got some alternate strategies, like now if the patient's airway is good, extracting third molars and distalizing the dentition could also be thought if the patient is a classical borderline case, and if you feel that extracting premolar might make the incisor retraction more than what is required. Okay. Another thing is going for second premolar extractions, where you can have more control on the mesial movement of the molars or the anchors. So this was a patient who's daughter of my very good friend from school. She came when she was young, and she had upper proclination and lower crowding. So we told her that you need extraction. She was very scared, and she said, no, I don't want to get the extraction. You want to treat, you treat without extraction. So we said that we can't treat you. So my friend had a job where there are a lot of transfers involved. So he got transferred at a particular place, went to an orthodontist there, got the treatment done as per her wish, because that orthodontist was also saying that you require extraction. But she was insisting that I don't want to get extraction done. You treat the way you can without doing extraction. So the crowding which was there in the lower arch got resolved by proclining. The upper proclination which was there didn't get corrected because there was no space. And this is how she came back after around 7 years post debonding, saying that my teeth are not satisfactorily gone in, they are not aligned. What should I do? And when I asked, you were told about extraction, she said that you said the same thing. The orthodontist there said the same thing, but I convinced her to treat me non-extraction. But this is how she was. So look at the proclination. Look at the proclination, look at the lip strain. Okay, there's a lot of lip strain which is there. So we went ahead. You can see this is how the retainers were also in place. Okay. Then we decided that no, we convinced her, we got the extractions done. About the extraction also, she was very finicky. So she went and got the extractions done somewhere out. Anyway, I don't do general dentistry. So I usually send my extractions to an oral surgeon who is a friend of mine. But she got the extraction done, and look at what the general dentist did to the cortical plates, fractured all the cortical plates while doing the extraction. Okay, so it increased a lot of mechanical stress on me, because I had to move these teeth in an area where there is no bone at all. So this is how you can make out the retainers were also in place. I don't know how the retainers were given with the space in between, but they were bonded. Okay, then we went ahead, and this is how she finished. And it took a lot of time to close the space in the area where cortical plates were. Now you can see the smile aesthetics here. What I want the PG students to know here is that don't only look at the nasolabial angle, and don't only look at the non-extraction modality as the only modality. There are cases where extraction is definitely going to be required. Look at this. Now there is a good root parallelism which we have achieved. Look at this. There's a little bit of increase in the nasolabial angle, but look at the inclination of the incisors. Look at this. And look at this. What happened is that when you treat non-extraction, there is a tendency of flaring. And whenever there is flaring that happens, the most common thing which is going to happen is the flattening of the smile arc. And when you retract, the incisors have a tendency to extrude more. So when you're retracting in such cases, it actually deepens the bite, which has to be opened by intruding the lower anteriors. But this a little bit of extrusion of upper anterior helps in making the smile arc more consonant. So this particular patient's smile became consonant because the smile arc got better with the lower lip. So this is how the patient was. Then the next controversy comes is the camouflage versus orthognathic surgery. So I will just, because this will be taken in detail by Dr. Umal. So you have to remember that acceptable results will be there if you do a camouflage in cases where there is skeletal malocclusion, if the patient's growth pattern is average or short, there is mild anterior-posterior jaw discrepancy, crowding is less than 4 to 6 millimeters, and the soft tissue features are normal, and there is no transverse skeletal problems. And it will not give a good result if the patients are having vertical facial proportions, moderate to severe anterior-posterior jaw discrepancy, crowding more than 4 to 6 millimeters. The facial soft tissue features are exaggerated, like a deficient chin or prominent nose, and the patient also have an associated transverse or skeletal problem. So there are, remember that these difficult correction, especially in long cases, you'll be given some difficult correction. The skeletal deformities which are not easily corrected by orthodontics or growth modification alone are mandibular prognathism. There is insufficient evidence about controlling the mandibular prognathism in class 3 individuals. Then vertical maxillary growth deficiency or excess, both VMD as well as VME are little difficult only to be treated by growth modulation. But now with the advent of implants, we can correct maxillary excess. Chin deficiency, even if you do a good skeletal correction, the position of the mandible will get corrected. But if the anatomy of the chin is deficient, then genioplasty is the only solution. There are some classical contraindications to camouflage it, which you should remember: severe single jaw imbalance, skeletal class 2 with maxillary and mandibular deficiencies, which could be there, and true skeletal class 3. And from seminars in orthodontics published in 1999, they have mentioned successful orthodontic treatment is less likely when excessive overjet is accompanied by any of these findings. Pogonion to Nasion perpendicular distance is greater than 18 millimeter. Mandibular body length is less than 70 millimeter. Face height ratio is greater than 125 millimeter. The anterior facial height is more than 125 millimeters. That's a very long face syndrome. And I will give you, 5 points. Out of these 5 points, any of the 3 of the above conditions are met, then consider them as a surgical case. And this is very important for your long case. You have sufficient time, analyze the case properly. See if the overjet in a class 2 patient, if the overjet is greater than 10 millimeter in non-growing patient, Pogonion to Nasion perpendicular distance greater than 18, mandibular corpus less than 70, face height greater than 125, and A and B angle greater than 8 degrees. Out of these 5 things, if any of the 3 are met, then don't treat this case with camouflage. Treat it with orthognathic surgery. And in class 3 patients, similarly, if the reverse overjet is more than 4 millimeter, skeletal disparity more than minus 5 mm, mandibular body length more than 105, face height greater than 125 mm, and A and B angle less than minus 3 degree. So out of these 5, any of the 3 above conditions are met, then do not treat this case with camouflage. It is always better to go in for the surgical correction. So this was a class 2 division 1 type of malocclusion. We started non-extraction, realized that the molar relationship cannot be corrected, so we decided going for single arch extraction. We did upper 4-4 and we finished in a class 2 molar relationship. This is how the patient is post-treatment. Now this particular patient is an interesting case. Look at this intraoral finding. It's a class 2 division 1 malocclusion, and when we see the cephalogram, we see that there is a severe chin deficiency and chin anatomy issues which are there. So we discussed the case with the patient. We told the patient to remove the beard and come, and then you can make out the facial proportions are not correct. The throat length is also less. So we discussed with the patient, gave him the option that we need a surgical correction. The second option was to go in for only dental correction, but definitely a genioplasty. And the third option was only orthodontic treatment. And we explained him that if you just do an orthodontic treatment, your aesthetics will not be good. So we convinced the patient. The other option was retraction followed by genioplasty. But the retraction, if it is followed by genioplasty, the nasolabial angle wouldn't have, would have mattered here. Because if you are just doing a retraction, the nose would have looked more prominent. So we convinced the patient for surgery, but the intraoral findings were class 1 molar. So we had to do a decompensation. So we extracted upper 5.5 and lower 4.4, and we retracted upper incisors as less as possible. We did mesialization of upper molars and retraction of lower anteriors. So we, from class 1 Bimax, we converted this case into class 2 division 1. You can see your molars have come in class 2. Incisors are very minimally retracted. Lower incisors retracted sufficiently so as to go in good overjet. Molars, upper molars have mesialized to get this case into a class 2 division 1 type of relationship. This is how the patient is just before surgery. And now you can make out here, we did a BSSO with advancement and a genioplasty. And there is a good improvement in the patient. A little bit of, no, I don't think nasolabial angle also has changed much. So this is how the patient immediately after surgery. This is immediately after surgery. This is immediately after surgery. You can see BSSO with genioplasty. This is how the patient is. And then this is the finish. You can see here the facial aesthetic looking great. This is now intraorally again back to class 1 molar, canine and incisor relationship. He's not ready to get this particular restoration done. He says that's my characteristic. Convincing, but it's not happening. So this is how the patient is. The chin anatomy is improved very nicely. So this is where the controversy of camouflage versus surgical will come. This is the patient. Now there are cases where Chetan, I'll just finish in 5 minutes. Is that okay?
Yes, absolutely. Take your time, Jayesh.
So this is the case which came to me. Is this patient is a daughter of a very reputed dentist in Pune. The patient already had undergone orthodontic treatment, but because of late mandibular growth, that too asymmetrical, there was a crossbite which was developing. The patient had a constricted maxilla. So we started initially, we did a lot of analysis. We thought that we might be the patient's age was 17. We thought that we should go ahead with the RP, and we tried RP, but the expansion didn't happen because the sutures were completely closed. Then this was one of the first few cases which I did with MARPE. So this is the microimplant assisted rapid maxillary expanders. So this is how the expansion took place. The implant had slipped a little bit, but that was after the expansion was achieved. So this is how the progress of expansion. This is the modified Zachrison's TPA, which we give after extraction, after expansions are achieved. This is TPA in place. This is how the patient is. This is progress. This is immediately after expansion. And this is after completion of proper comprehensive orthodontic treatment. You can make out the crossbite is completely corrected. The midlines corrected. Facial symmetry got corrected to around 50%. A little bit of chin prominence on one side is still there. I can't show the extraoral photographs of this particular patient because of I haven't taken the consent of the patient for showing the photograph. So I'm showing only the intraoral. So for the expansion, I would recommend all the PG students to go through this particular article by one of the legend of our Indian orthodontic fraternity, Dr. N.R. Krishnaswamy, where in APOS trend, Asia Pacific Orthodontic Society's journal Trends in July-September 2019 issue, there's a very nice article about expansion in the absence of crossbite, rationale and protocols. And very nicely has explained in which type of cases, what type of expansion is required. So please go through this particular article. So he has mentioned about in cases where crossbite is not there, what has to be done. In cases where crossbite is there, what should be used, which age you should use RP, which age you should use um, implant supported expansion, what should be the expansion protocol, how many turns. So it's very nicely given. And some people ask that after doing expansion, what happens to the buccal bone plate thickness. So this is an article by De Gregorio in AJODO February 2009. Please go through this article also. And this article by KJ Lee in June 2010 is where I got the idea of doing the MARPE, what I showed you just now. So that also you can see. This article by Fernanda Angiglieri in AJODO November 2013 is a very important article. It tells us about the mid-palatal sutural maturation, classification method for individual assessment before a rapid maxillary expansion happens. And very nicely, they have mentioned into stage A, B, C, D, and E. And there is a flow chart. So the first question you have to ask, can you see the suture along both the maxillary and palatine bones? So this is the maxillary bone and the palatine bone. So if the answer is yes, if the answer is no, can you see the suture only in the maxilla only? So you don't see in the maxilla, that is stage E. If you see in the maxilla only, not on the palatine bone, that means it's stage D. If you see sutures in both maxillary and palatine bone, you have to check is there any the two high density lines along the suture. If there are high density line along the suture, then it is a stage C. If there is no high density line along the suture where cortication has not yet started, then the next question to ask is one line you see is scalloped or non-scalloped. If it is scalloped, it is stage B. If it is non-scalloped, it is stage A. So if you follow this particular flow chart, you can categorize the case into proper stages, whether it is stage A, B, C, D, or E. So what they have proposed that at stages A and B, a conventional RMA approach would have less resistant force, and that is a method of choice to be used there. Probably more skeletal effects than stage C you will see. In stage C, if you use RMA, more dental effects will be seen. If you use RMA in stage A and B, more skeletal effects will be seen. Okay. Initial diagnosis of stage C might indicate that the timing of RMA is critical because start of fusion of the palatine portion of the suture could be imminent. Patients in stages D and E might better be treated by surgically assisted RMA because fusion of the mid-palatal suture has already occurred. So in stage D, in stage C and D, so the rough idea could be A and B can go for RMA. C will have a 50-50 chance. You can give RME first. If after giving 8 turns, if there is no midline diastema which is opening, that means the fusion is very strong. So you have to stop RME and go for microimplant assisted expansion. So those cases of C and D you should treat with MARPE. But whether stage E is amenable to MARPE or not is not doesn't have sufficient evidence. So I will keep my comments reserved about use of MARPE in stage E. You can try it, but it's always better to have corticotomies along with these MARPE, that is microimplant assisted expansion. So stage E, it is always better that you go in for surgically assisted expansion, or you can do MARPE along with micro osteoperforation. So think of these. So this is how stage A will look like, single line. Stage B will look a single line, but which will be scalloped here. You can see there is scalloping. Okay. Stage C, you can see the whole suture, but there is condensation of the line which is seen. Stage D, you can see the suture only in the maxillary, not in the palatal bone. And stage E, where you can't see the suture in the maxillary as well as in palatal bone. So I keep my comments reserved. There is insufficient evidence to comment whether stage E is amenable to microimplant assisted rapid palatal expansion. You can try MARPE along with microosteoperforation and try it out, but down. So instead of MARPE, what you can do is that you can use MSE. MSE is where the MARPE are the microimplant assisted expansion where monocortical engagement is done by the implants. So Some dental expansion will also be associated with MARPE, but maxillary skeletal expanders which use bicortical engagement, that is the concept which is given by von Moon, has shown that there is less buccal flaring. So cases where there is a crossbite and you need to do microimplant assisted expansion, but the buccal occlusion is showing a little bit of flare, it is always better to go for a bicortical engagement. So the further flare and palatal cusp hang downs will be lesser. So you can go for these type of expand. This is by Fav Anchor, Favex, by our own Dr. Vivek Patni and Dr. Sheetal. And this is the occlusal X-ray. And here you can see there is a bicortical engagement which is done by the MSc. So in conclusion, we have to remember that orthodontic treatment decisions are based on multifactorial analysis, and you have to be very methodical in analyzing every diagnostic record and evaluating its interaction amongst each other. You have to think of each case in X, Y, Z planes, okay, anteroposterior, transverse, and vertical, with T as the factor, that is growth. In growing patients, you have to consider about what is the growth vector, whether it is normodivergent, hypodivergent, or hyperdivergent. At the same time, you have to remember there is a pitch, yaw, and roll in the jaws which can happen. So not only evaluating this, but considering this is very important: pitch, yaw, and roll. Then to that, we need to evaluate the soft tissue paradigms. Don't base your treatment decision only on the skeletal readings of cephalogram, lateral cephalogram, or PA cephalogram. Think about newer methods of treatment also, because there are newer methods, as I said, about IZZ, buccal shelf implants. Some borderline cases can be treated with third molar extraction or enucleation. Those third molars, if they are missing, then rather than extracting, if the airway is good, if the divergency of the patient is good, then you can think of distalizing the whole dentition, all those things. In soft tissue paradigm, what is most important, you have to think about the airway, lips, and the tongue also. So remember this, and always make evidence-based choices. If the new evidence comes, this I'm telling you not only from the exam point of view, when you start practicing, don't just practice what you are taught now. As the science develops, try to unlearn things which doesn't have evidence, or where the evidence says that this doesn't work. Eliminate them from your practice. Try to learn about new things and relearn which have been proven to be useful. And in orthodontics, what is most important is to have patience, and remember, the wisdom comes with patience. So if you do all these things, you will be successful in eliminating the controversies and the uncertainties of the whole branch, the treatment planning, not only during the MDS examination, but also during your clinical practice. So I stop here. Thank you very much for your patience listening. These are my contact details. Plus,